With regard to the knee is injured fairly frequently, often related to sport or athletic injuries. And the reason the knee gets injured so frequently is that its fundamental anatomic design is not so well suited to its function in certain ways. When we talked about the shoulder earlier, we talked about how the shoulder is not built in a way that's stable because you had a big round articular surface articulating with a flat articular surface, and we said that's inherently unstable. But that was okay for the shoulder because we wanted the shoulder to be mobile. In the case of the knee, we again have a big round articular surface. This time it's the femoral condyles, articulating with a very flat surface, in this case the tibial condyles. So we have a round femoral condyle articulating with a flat tibial condyle. That's inherently unstable. That's not okay for the knee because the knee has to support weight, so it needs to be stable. So to add stability to the knee, there are other tissues that are added to the knee to improve stability. Firstly, we have the menisci. We have a medial meniscus and a lateral meniscus, which are inserted between the femoral condyle and the tibial condyles, one on the medial side, one on the lateral side. An important element of the structure of the meniscus that contributes to this improved stability is that the meniscus is built in such a way so that its bottom surface is flat and its top surface is concave. So by inserting the meniscus, we've improved the fit between the round femoral condyle and the flat tibial condyle by having the upper surface of the meniscus be concave and thereby have a better articulation with this convex femoral condyle. So that's one important function of the menisci. Secondly, if we want to improve stability of the knee, we need to limit mobility of the knee. So one way of limiting mobility is by adding ligaments that limit the directions in which the knee can move. And so we have a medial collateral ligament, also referred to as the tibial collateral ligament, and we have a lateral collateral ligament, also referred to as the fibular collateral ligament. And those medial and lateral collateral ligaments prevent medial and lateral movement of the tibia and fibula upon the femur. In other words, they prevent abduction and adduction at the knee. So the medial collateral ligament prevents abduction of the leg, and the lateral collateral ligament prevents adduction of the leg. But again, thinking about how the lower limb is used, we don't usually have forces that pull the leg medially or pull the leg laterally with the limb hanging freely, but conversely, we usually have the foot planted in the ground supporting weight. And so while the foot is planted on the ground, if a force is applied to the knee from the lateral side, it will drive the knee medially, which is the same as driving the leg laterally. So that will stretch the medial or tibial collateral ligament and can tear the ligament. So a common mechanism for tearing the medial collateral ligament is a blow to the lateral side of the knee, what's called a valgus stress to the knee, which can stretch or tear the medial collateral ligament. Similarly, with the foot planted on the ground, a blow to the medial side of the knee, which is the same as a medial movement of the leg, will stress the lateral collateral ligament. That's called a varus stress. So a blow to the medial side of the knee can tear the lateral collateral ligament. So medial collateral ligaments are tears of the medial collateral ligament are much more common than tears of the lateral collateral ligament because of the mechanism of injury. The lateral side of the knee is much less protected, and so it's easier for somebody to run into the lateral side of your knee than it is to run into the medial side of the knee because you have the other leg protecting the medial side of the knee. The other important issue here is to take note of the fact that the medial meniscus and the medial collateral ligament are fused together. In contrast, the lateral collateral ligament and the lateral meniscus are not even close to one another. There's actually a tendon that passes between them. So because of the fusion of the medial meniscus and the medial collateral ligament, that means that the medial meniscus is not able to move around inside the joint. It's pinned in place by its fusion with the medial collateral ligament. In contrast, the lateral meniscus is much more mobile and can slide around inside the joint. And it's for that reason that tears of the medial meniscus are much more common than tears of the lateral meniscus. Because with torsion injuries, while weight-bearing, with gravity pulling the femur down against the meniscus, if there's a rotational force on the femur, that rotational force will rotate the femur. The lateral meniscus will tend to move with the femur, but the medial meniscus is pinned in place, so you have gravity pushing or pulling the femur down against the medial meniscus, and then as it rotates, it will tear the medial meniscus. So medial meniscal tears are more common than lateral meniscal tears. We've already said that medial collateral tears are more common than lateral collateral tears. The last ligamentous structure in the knee that's important for improving stability is the pair of cruciate ligaments. The cruciate ligaments are internal to the knee. They are within the joint capsule, in contrast to the collateral ligaments, which are outside the joint capsule. The cruciate ligaments are inside the joint. We have an anterior cruciate and a posterior cruciate ligament. Each ligament goes from the tibia to the femur. The anterior cruciate ligament is attached anteriorly on the tibia and posteriorly on the femur. The posterior cruciate is attached posteriorly on the tibia and anteriorly on the femur. Those ligaments prevent anterior and posterior displacement of the tibia upon the femur. To appreciate how those ligaments operate, it's better to look at this in a lateral schematic view, as we do on this slide. And so we can see on this slide, we see the posterior cruciate ligament illustrated. And we can see how if we follow that arrow, if we push the tibia posteriorly, we would be stretching that posterior cruciate ligament. So the posterior cruciate ligament prevents posterior displacement of the femur. And similarly on this side, we see the anterior cruciate ligament, and we see this arrow indicating anterior displacement to the tibia, and we see how anterior displacement to the tibia would stretch the anterior cruciate. So the anterior cruciate prevents anterior displacement to the tibia upon the femur. Recognize that anterior displacement of the tibia is exactly the same movement as posterior displacement of the femur. So we can say that the anterior cruciate either prevents anterior displacement of the tibia or posterior displacement of the femur, and then conversely for the posterior cruciate ligament. And the other point illustrated on this slide is that during knee extension, you tend to get a posterior displacement of the femur. So extension at the knee tends to stretch the anterior cruciate, and conversely, flexion at the knee tends to stretch the posterior cruciate. So since extension of the knee tends to stretch the anterior cruciate ligament, that means hyperextension of the knee. Hyperextension injuries of the knee are apt to tear the anterior cruciate ligament. So of the two cruciate ligaments, the more commonly injured ligament is the anterior cruciate ligament for that reason. So what we've said is that the anterior cruciate ligament is injured more frequently than the posterior cruciate. We said that the medial collateral ligament is injured more frequently than the lateral collateral ligament. And we said that the medial meniscus is injured more frequently than the lateral meniscus. And there is a coincidence of injuries that's sometimes given the name the unhappy triad. There are certain athletic injuries, particularly in football and soccer, where there are strong blows to the knee while the foot is firmly planted in the ground. And those injuries can cause all three of those ligaments or structures to get torn. So anterior cruciate tear, medial collateral tear, and medial meniscal tear oftentimes coexist from the same injury.